Your slides are not up yet.
To add to this conundrum of acronyms, I'm here to add two more to the I should say the basket, and I'll be talking about ectopic inner foveal layers and tractional central bouquet abnormalities in patients with epiretinal membranes. So what is EIFL? EIFL basically means ectopic, stands for ectopic inner foveal layers, and this refers to the OCT appearance of banded tissue, which represents, which is very similar to the inner nuclear and the inner plexiform layer of the normal retina. Now this appears on the top of the fovea in the foveal region where it is not supposed to be, and that is why it is referred to as ectopic. Now this is the representative OCT that was given in the original paper that described it, where you have, this is the foveal region where you have this layer that is similar to the inner plexiform layer and the inner nuclear layer here. This is one of our cases which has a similar appearance. Now based on this, the authors have classified epiretinal membranes into, or staged epiretinal membranes into 4 stages. The stage 1 has an epiretinal membrane with an absolutely preserved foveal architecture. In stage 2, there is elongation of the outer nuclear layer and the foveal dip is absent. In stage 3, you have these ectopic layers coming up and the retinal layers can still be distinguished. In stage 4, you have the ectopic layers, but you cannot, there is disruption of the retinal layers and you cannot make out the retinal layers very clearly. So these are clinical examples. These the first, the ones on the left are examples of stage 1 epiretinal membrane. This one is a stage 2 epiretinal membrane with the absent foveal dip. These two are examples of stage 3, and these two are examples of stage 4 epiretinal membrane, where you can see there is tissue here. You cannot make out the distinct layers of the retina. Now, epiretinal membranes, approximately 15% of membranes in their study over about 2 years progressed from stage 1 to stage 2, stage 2 to stage 3, and stage 4. The proposed mechanism that the authors propose is that tractional alterations bring together these layers, and there is physical displacement of these layers, which can you can appreciate on the OCTA by seeing the closer, the moving, the absence of the foveal vascular zone, and the capillaries that surround the foveal vascular zone have been brought to the center. They have also proposed something called a Muller cell-driven proliferation of retinal elements that causes these layers to build up in that area. Very doubtful though. Now there's another, before I go to the clinical relevance, let me describe the central bouquet abnormalities now. The central bouquet is an area of central fovea that is about 100 micron in diameter, and this has a peculiar arrangement of the cones and the Muller cell cones, the special Muller cells called Muller cell cones in that area. And the abnormalities that are that happen when this particular area is subjected to traction are the cotton ball sign, which is a thickened hyperreflective fuzzy area below the epicenoid zone and the above the interdigitation zone. Foveolar detachment is a normal subsensory neuro hyperreflectivity at the fovea, and an acquired vitelliform lesion is the name given to a dome-shaped hyperreflective material accumulation that happens between the EZ and the RPE. So these are the 3 examples. This one is an example here of the fuzzy cotton ball sign. This is a neurosensory detachment, and this is acquired vitelliform lesion in a case of ERM. These are our examples where you have this fuzziness at the fovea. Again here, it's almost evolving into a neurosensory detachment. And another one example here. So this is a neurosensory detachment here. Now, the proposed mechanism which has been offered by the authors is that there is vertical traction, and these Muller cells here, they have applied traction on the cone cells, initially causing elongation, which gives you the fuzzy sign, cotton ball sign, and then causes a detachment here, and then when these degenerate, there is accumulation of hyperreflective material at the fovea. So what is the clinical relevance? Now, the clinical relevance is such that the ERM, stage of the ERM correlates with the visual acuity and with the retinal thickness, and there is progression of ERM seen in about 17% of cases. However, the progression from a stage 2 to a stage 3 with the appearance of ectopic layers happens in about 13% of cases. Tractional central bouquet abnormalities are seen in about 22% of cases, and cotton ball sign is present in 2/3 of these cases, most common. And in 15% of cases, you have progression of CB abnormalities. Again, in the central bouquet abnormalities, the cotton ball sign is associated with the best visual acuity, and the worst visual acuity is seen in cases that have a vitelliform lesion, acquired vitelliform lesion at the fovea. And the recovery after surgery is also similar. As far as the prognostic importance goes, stage 3 and stage 4 ERM fare worse, and stage 1 and stage 2, if operated upon, fare the best. This is a representative graph which shows that the stage 4 ERM, though it improved dramatically after surgery, but never reached the level of visual acuity that a stage 2 ERM did. The same happens with central bouquet abnormalities. Patients who have acquired vitelliform lesions don't do that well after surgery, whereas patients who have a neurosensory detachment and a fuzzy cotton ball sign, they do much better. These are representative examples. On the left panel, you see an example where surgery has been done, and the lower bottom panel shows you that the ectopic inner foveal layers are still present after surgery. They have not completely disappeared. Whereas on the right panel, you see that the ectopic inner foveal layers have disappeared, and there is an actual normal foveal contour, even though there is a little bit of perifoveal thickening. Now, the points to ponder, the ones that I would like to discuss in this meeting is, I would be very happy with the staging of the epiretinal membrane, but something which I could not digest was a de novo appearance of very organized, layered ectopic retinal layer on top of the fovea. Where did this tissue come from? My guess is that because in a case with a thick ERM, stage 4 ERM, a hyperreflective membrane happening occurring over the fovea is sometimes difficult to locate. Because of the tractional forces of the ERM, it may be displaced a little bit above or below the point where you actually think that fovea is. You cannot identify the fovea, and any scan which is even 5 to 7 micron away from the absolute center of the fovea will give you this layered pattern. These are the normal retinal layers that have been brought together by the traction. The other point that I found a little controversial was disappearance of EIFL in some cases where it did not, whereas it did not disappear in other cases. What happened to the cases where it disappeared, and what different happened where it did not disappear? So based on this, I just have 2 or 3 slides where I wanted to show. This is a patient who would have been classified as a stage 4 with the EIFL with the disorganized retina. If you go above and below, you sometimes may be able to see a place where the retina is infolded here, and the adjacent layers have been brought closer together. So this may appear continuous. Just above or below the scan, they may appear continuous and may appear as ectopic. So on magnification, you can make it out very clearly. Again, this is a small video that demonstrates the same. So I have paused it. So this is, at this point, you would call it EIFL, but here you can see that there is a folding, and the outer nuclear layer stretches up to the very top. Again, another example, this is stage 4 here, but if you look here, this is less clear here, but there is an infolding of the foveal layers, and the surrounding layers have been brought closer together. So the mechanism which I thought of, maybe true, maybe not true, is that there are 2 types of patients with ERM. In the first type of patient, the adherence between the neurosensory retina and the RP is less stronger than in other cases. And here, the tractional forces of the ERM cause a vertical lift or vertical force vector happening at the fovea, and that causes the stretching of the cones and the detachment. Whereas in the other kinds where you have a very strong RP attachment to the neurosensory retina, the force vector will be directed inwards, and this will bring in the layers from the sides and cause an infolding, and that here would appear on the OCT as a ectopic inner foveal layers. Now, I leave it open to the house to discuss the validity of my hypothesis versus the one that is been proposed. Thank you.